Good evening. It is my pleasure to welcome all of you to tonight's presentation on triple-negative breast cancer. As you're probably aware, San Antonio was held last week, and for many of us, we were watching things virtually, but some of us got to attend the meeting in person and some did a little bit of a hybrid. And so it's my pleasure tonight to introduce you to our team and our roster that will help to navigate some of the new things that came out at the meeting just last week. It's kind of like that Monday morning football look back and say, what are we going to be doing now going forward? The first speaker I'd like to introduce will be our panelists. This is going to be informal. We welcome questions throughout our presentation, but we also hopefully will get some good chatter with us. Our first speaker and panelist needs no introduction, Dr. Terry Mamounas. He's the director of the Comprehensive Breast Cancer Program at Orlando Health. I think everybody is very well aware. They've seen Terry on many platforms, and he was one of the lucky ones that was actually in San Antonio and got a chance to give a live presentation. And he's going to share with us some of what he talked about there on management of the axilla, particularly in our early stage patients. Our second panelist I'd like to introduce you to is Dr. Tiffany Traina. And Tiffany is the vice chair of the Department of Medicine. I didn't even know that until I looked this up, Tiffany. You never even told me that. So, you never know what some people do behind scenes. I know how that is. But what I did know is that you are actually the section head of the triple-negative breast cancer clinical research program at Memorial. And you're going to be able to give us a great deal of insight into some of these studies, how they got to where they were, why they have some of the inclusion exclusion criteria. And I think more importantly, we're going to ask you to look at that crystal ball and sort of tell us where do you think we're going to go with some of this information in 2022 and thereon. There will be another panelist joining us as well, Maimah Karmo, and she is the founder and CEO of the Tigerlily Foundation. Many of you probably know that she is the inspiration for so many of our patients, particularly our patients of color, and helping them to go through their treatment journeys and keep upbeat. And I think she's going to be joining us as we go along today. I didn't introduce myself. I just realized that. I'm Elyse Lower, and I'm from the University of Cincinnati. And so with that, I'd like to start off, and we're going to talk about several abstracts and presentations. We'll start with our early triple-negative breast cancer patients. And I'd like to start by talking about Keynote 522, which I think is going to be practice changing for so many of us. I know we even talked about this at our tumor board today. I'm going to give just a 1-minute overview for those of you that may not be that familiar with what the study was and what the endpoints are, and then we'll talk about how we think this may fit in our world. So this was a randomized, multi-center, double-blind, placebo-controlled study looking at the value of neoadjuvant pembrolizumab, I'm just going to say Pembro from now on, plus chemotherapy versus placebo plus chemotherapy in early stage triple-negative cancer. There were 1,100 plus patients randomized 2-to-1. I think the entry criteria is interesting here because it's a little different than some of the other Keynote studies. Tumor size greater than 1 centimeter, less than 2 centimeter, with or without nodal involvement. And if you did not have nodal involvement, the tumor had to be 2 centimeters in size. And one of the interesting things is patients could be enrolled regardless of their PD-L1 status, which is a little bit different than some of the other Keynote trials. The patients received neoadjuvant chemo. The first 4 cycles were Pembro versus placebo plus paclitaxel. And then cycles 5 through 8 were adriamycin or epiribicin. Most of us use Adria in the US, along with standard dose Cytoxan. And it was given every 3 weeks and not dose since. The reason I'm pointing that out is my colleague tried to get this approved today and the insurance company wouldn't approve dose dense AC. So anyway, I guess it has to be pretty specific. And this was followed by Pembro every 3 weeks for a total of a year. The main outcomes were pathologic complete response, which is what we are always looking at in our NEO trials, along with event-free survival, with the usual other secondary outcomes of overall survival. And the results were quite positive. There was a 63% complete response rate with neoadjuvant Pembro versus a 55.5% with just placebo, giving then absolute benefit of 7.5%. when they analyzed the study at a median follow-up of about 39 months, in the patients who received Pembro, there were about 16% had events versus 24% of patients, those patients that received placebo. So obviously, this means that this is a regimen that needs to be considered for our patients with early stage triple negative cancer. One other tidbit is I did subset analysis, and in every subset, be they node positive, node negative, stage 2, stage 3, menopausal status, or HER2 0 versus HER2 1, 2, still considered to be technically negative, Pembro seemed to be the winner regardless of the subgroup analyzed. So with that as a little introduction, Tiffany, Keynote 522, do you think this is practice changing, or what do you think about this as a way for us to treat our patients in this setting?
Yeah, thank you. So I sure do think this has been practice changing since we first saw these data at a sort of an interim ESMO presentation over the summer, and leading to an indication for us to be able to use Pembro in the neoadjuvant setting for our patients. I think there were a few things to call out. One is that we need to recognize that the patients were deriving benefit regardless of PD-L1 status. So I think it's important to remember that we do not need to test for PD-L1 status in our patients with early stage triple negative breast cancer. That's different than the metastatic setting, and I'm sure we'll talk about that a little bit later. I will say, as we think about which patients we're considering pre-op chemotherapy and Pembro in my practice, I've kept this pretty aligned with the eligibility criteria of a tumor 2 centimeters or greater if node negative or node positive, and have administered the treatment with the full complement of chemotherapy. So I know something I'd love to hear what you all think about is how much is the carboplatin contributing. But at this point, if I'm going to follow a Keynote 522 regimen, I'm using the whole complement of taxane, platinum, anthracycline, cyclophosphamide, as well as the Pembro in the pre-op setting. Another point I think I would just want to also mention is that in this particular study, adjuvant capecitabine was not used as part of the study for those patients who failed to have a pathologic complete response. And we did see some subset data of the proportion of patients who did go on to get capecitabine anyway, and it looked like there was still a benefit to pembrolizumab overlapping with that capecitabine for the sort of unplanned portion of patients who received what we would otherwise consider a standard of care in those who fail path CR. So those are just some initial thoughts. I'm sure there's a lot more to cover as well.
Yeah, let me bring up just a couple questions about one of your first comments, which was there was no PD-L1 testing to get into the study, which I think is great. But then it comes up, then is PD-L1 testing going to enrich the population? Would you perhaps not treat some patients? Clearly, we don't know the answer to that, I guess, because we didn't study it. Do you think that's a fault of study design? Did we just get lucky and have an enriched population? Or do you think really checking for PD-L1 is not going to be important? And
yeah, I think it's a great question. Whereas in advanced disease, we have seen that the degree of PD-L1 positivity by, say, CPS score really did associate with improved PFS and OS. In sort of retrospective analyses, we really haven't seen PD-L1 status be a necessary requirement or predictor of benefit. So I think that the early stage setting may clearly differ from the advanced setting.
do you think there's acquired resistance?
I don't know enough about that just yet.
Yeah, I don't know if, I'm sure that's an area ripe with lots of investigation to try to sort out why is it important in metastatic, but not in early stage disease. Yeah. So as we ponder that, and we are going to talk a little bit about the follow-up on Keynote 355, which did talk about PD-L1 cut points in the metastatic setting, and we're going to talk about that a little bit later. But Terry, as a surgeon, how comfortable are you using the criteria of T1C or above in early stage disease for neoadjuvant? Is that a good thing, bad thing, or? I think you're muted, Terry. I can't hear you, sorry. The wonders of technology.
Sorry, haven't solved. So I think it's important because, again, what we realized that, of course, it's not for everybody. It's for particular subtypes of breast cancer, namely triple negatives and HER2 positives. Because what we realize in those patients is that you can actually improve on patient outcomes depending on what happens with therapy, an option that you don't really have when you give adjuvant therapy. Namely, for triple negative breast cancer, the addition of capecitabine has improved outcomes. For HER2 positive breast cancers, obviously, the addition of TDM1 and other antibodies eventually that are coming. So I think that's an important component of the treatment, to be able to document response. And of course, to also be able to downstage the disease in the local regional level and obviously potentially decrease the extent of local regional therapy. And although even for a T1C patient that it's clinically non-negative and you could still do surgery and you can do a sentinel lymph node biopsy, potentially sometimes you'll find subclinical disease in the nodes. And of course, again, that doesn't necessarily necessitates an axial dissection all the time based on the results of the Z11 and some other trials that actually were also discussed in San Antonio. But in general, I mean, for particularly more aggressive tumors, when you see disease in the nodes, some patients may end up getting an axial dissection. So that allows also the escalation of the management of the disease in the axilla, but also the escalation of the management of the disease in the breast as well, the surgical management, converting patients from mastectomy to lumpectomy. And of course, the small tumor patients most likely would be a lumpectomy candidates. So it's not a requirement that every TN1C patient should get neoadjuvant therapy, of course, but I think you do gain potentially in long-term outcomes by doing so. And I think that's a major advantage that I see. It used to be the local regional management, but now I think is the fact that we can actually improve these patients' outcomes by treating them appropriately. If they get a pathological complete response, de-escalate some of the systemic therapy as well, potentially, but also if they don't, then escalating or changing the adjuvant therapy. And I think that's been important.
Yeah, I think that's really key. I was struck by the fact that, 5 years ago, if anyone would told us there was a regimen in which you'd see 60% complete pathologic remissions in neo and triple negative, we would have gone never, which is really interesting. So I think we're getting much better with our systemic management, which in turn clearly impacts surgical management. No two ways about that.
And if I can add, I mean, the Keynote 522 also showed that if you have a high proportion of PD-L1 positive patients, CPS over 10, it's a prognostic factor of degree of pathological complete response, not a predictive factor of benefit from pembrolizumab, but a prognostic factor almost to the point of 75, close to 80%, which kind of reminds me what it is in HER2 positive breast cancer, hormone receptor negative HER2 positive. So we can identify subgroups. And I agree with you. I think it's fantastic that we went from pathologic response rates, 10%, 15% before the taxanes to now 80%. It is phenomenal. So,
So very exciting. I think it'll be fascinating to see where we are in 10 years with these patients. Yeah. And actually, we'll talk a little bit about the patient impact with that too, because that I think is dramatic for them. They're so used to hearing how bad the prognosis is with triple negative. And now I think we have some really good data to suggest that we're seeing so many more complete remissions, which is really helping. There is a question in the chat for you, Terry, which is, in the current setting, which patient with triple negative breast cancer would you offer surgery first? Are there any patients in which they should not get neo?
Definitely, I mean, patients with T1A, T1B, obviously they'll do surgery first. And, small T1Cs, obviously you can still do surgery first. But particularly, I'll ask my medical oncologist, would you give different systemic therapy if the T1C patient has negative nodes versus if he has positive nodes? And if the answer is yes, then I would probably proceed with surgery first and let them then decide what appropriate therapy will give. So that would be the criteria. But if my oncologist says I give this patient, anthracycline taxane-based regimen, then I will say, why not do it in the neoadjuvant setting? I mean, I think that's the issue. Now, whether, carboplatin will come to that as well, I'm not sure. But interesting that we mentioned that before, because the brightness study data came out as well and showed that despite not only carboplatin improved on PCR rate, but also there was an EFS benefit. Obviously, some other studies did not show that. Most of the studies are underpowered, but I think, and we also complete one study now at NRG, BR003, which again, in and of itself probably will be small to get results. But I mean, when we ever meta-analyze these patients, probably we'll see some trend, I'm hoping, with carboplatin. But that's also interesting about 522 is that it showed all this benefit despite maximizing the chemotherapy. I mean, they were all out. There was no shortcuts there. So I think that's very, very interesting.
Yeah, yeah. So Tiffany, let's go back down to the chemo drugs again. So would you treat a T1A, let's say 4 millimeter triple negative? So obviously I don't think we'd offer her Neo. That's an easy probably answer. But what about adjuvant for a 4 millimeter triple negative in a otherwise healthy woman? Let's put her as, healthy and certainly able to withstand chemo. Where's the current state of the art with that now?
Yeah, I think the question of how low do we go, is something that we faced with HER2 positive breast cancer, where we had great drugs and we were able to sort of de-escalate in some circumstances and really balance risk and benefit of intervention. With triple negative breast cancer, I would say really tumors under 5 millimeters, I am not giving chemotherapy for. Clinically node negative. I really want to be cognizant of the harm that we can also cause and have equipoise there. So certainly in the 6 millimeter, 7, 8, 9 millimeter, this is not a place we would be doing neoadjuvant therapy, but I certainly have the conversations around systemic chemotherapy. And there, I think it's a much more nuanced discussion about risk-benefit balance of taxane cyclophosphamide versus anthracycline-containing regimens. I think we have a little bit more flexibility, but generally for me, once I'm over a centimeter, I'm often having that conversation about anthracycline taxane-based chemotherapy.
Mm-hmm. So what about carbo? I think, carbo every 3 years resurrects itself. We go from nobody needs carbo, everybody needs carbo, germline mutation carriers need carbo. It's so controversial. So so first of all, would you offer Keynote 522 as a modified version without carbo, or do you think carbo is an essential ingredient to getting such a high PCR rate?
So, I can't answer that from 522 because as Terry said, I mean, I think that it was designed with intention that we can never question that, well, maybe if you had a platinum in there, you wouldn't have seen that incremental add from the checkpoint inhibitor. So Keynote 522 won't answer that question for us. If I find somebody is high risk to warrant the Keynote 522 regimen, I am starting with the entire complement of taxane platinum followed by anthracycline cyclophosphamide. But if I needed to de-escalate, drop a dose, if someone's having difficulty, for me, the first thing that I would reduce is the platinum in an effort to make sure I'm delivering my taxane and anthracycline.
I think we all cut that way down. That tends to be the one that causes all the bad neuropathy and the platelets are too low, and it can really beat up the bone marrow, unfortunately, on occasion.
Yeah. And actually, to something that you had mentioned earlier about the dose-dense anthracycline schedule, I mean, this is a modification on 522, but we do have data to support the use of every 6-week dosing of pembrolizumab in areas where pembro is otherwise indicated. So in my practice now, since having these Keynote 522 data, I've started with taxane platinum with an every 3-week pembro. And when I reach my anthracycline, have administered dose dense and switch to Q6 pembro to coordinate the two. Friendlier for our patients. And I'm trying to squeak out every potential benefit from the dose dense scheduling.
There's one more question about the chemo drugs, which is, why are we giving the taxane first instead of the anthracycline? I thought we always started with anthracyclines. So obviously our original NRG back then in SABCS studies did start with that, but you want to comment on the ordering of taxanes versus anthracyclines?
So there's been data, and Terry can speak to this also through our cooperative groups, but there's been data in both directions, AC followed by taxane, as well as taxane, weekly taxanes first, followed by anthracycline. I don't think that we've seen one any better than the other. And so, I have used it in both directions, actually, in both sequence.
Sometimes if you're waiting to get something approved, you'll start with one. Like if you need cardiac clearance or something, for sure you're going to start with the taxanes or whatever. Yeah. So, okay. So as those of you who participated in San Antonio, Hope Ruga was a discussant for this abstract and a couple others. And she provided a very interesting schema on what she considered the current algorithm of treatment for early stage triple negative breast cancer. I think there's some discussion here. So first of all, as we've talked about, criteria would be T1C or T2 lesions, along with obviously any node positive. So if by chance you had a T1B with a positive node, that would be considered. Patients would get neoadjuvant, and it would be paclitaxel, anthracycline, Cytoxan, versus carboplatin, plus pembrolizumab. And again, her slide intimated that there would be some people she would not give pembro to. So let's start dicing it there. If we're going to give neo for triple negative, should everybody get pembro? Obviously, there's people that have autoimmune problems may not be able to, but would we offer pembro pretty much to everybody that meets the criteria? Do you have thoughts, Tiffany or Terry?
I think that if we're going to, if you've defined your patient as high risk of recurrence and warranting neoadjuvant therapy, 2 centimeter node negative and greater, node positive, then with both the path CR benefits as well as the event-free survival benefit, if I'm going to do that, I'm using pembro.
Yeah. Okay.
And the interesting, I think, data from San Antonio with the subset analysis, right, with no negative versus no positive, or stage 2 versus stage 3. And the benefit was there for both. Numerically, it was a little bit more for stage 3 or no positives by like 7-8%, but it was at least close to 6% EFS benefit from no negative. So it's not like the subgroup did not benefit. So I think that's important. I think a lot of debate, as you know now, is what you do after you achieve a PCR, right, where the patients do very well with maybe a couple % difference, and it could have been statistical,
So that's kind of nest on the tree. So if the patient gets a PCR at surgery, I think we'd all agree we should continue pembro for a year. And if I'm reading you right, Tiffany, you might go to Q6 week rather than Q3. Is that right? Or
yeah. I mean, I think that's certainly more patient friendly, and we've got data that dosing's comparable. So, yep.
Do you see less skin toxicity with the Q6? Because I know in some of the other tumor types, I think that was one of the issues. Do you know, have you seen that?
I don't know if anecdotally I've observed that. I think it's a convenience, and I see Maimah's joined us, but I think, just from a patient-friendly adjuvant therapy for a year commitment to be able to make sure our patients are out there living life rather than in the chemo infusion suite, that seems like an advantage.
Yeah, for me, to be honest, this San Antonio Breast Cancer Symposium this year was so powerful. I was late because I was getting my screening today. And as a Black patient who has triple negative, who's, thank God, 15 years cancer-free, who has dense breast, when you go to a doctor and get that call back, you're scared out of your mind, right? So that's why I was a few minutes late taking care of this very conversation, taking to myself. But for me, the best thing was having all these advances and options for TNBC patients. As many of you know, Tigerlily has a program called the Angel Advocate Program, where we send Black women to conferences like San Antonio Breast. And this year we had a 3-hour discussion on health equity and the importance of advances, multiple approaches to interventions for patients who are of color. So, there are people who had never been to San Antonio Breast, who are Black and brown women from communities that have the highest death rates, learning about all this data and about the importance of getting involved in science and having just these discussions. So I'm just happy to be here to listen, learn, and it's good to know that we'll see better outcomes for Black women based on what we learned at San Antonio Breast last week. So that's, to me, very empowering, impactful, And it's exciting, you know, because many people don't have the same outcomes that I have with triple negative, as all three of you know.
Absolutely. So thank you and welcome to our panel. And I don't think any of us will say you were not doing the wrong thing. So screening's important.
Yep.
I hope you're getting an MRI, you know.
I have to, you know, I have to be the example that I preach, right? You know, some of us who are in the healthcare space will be like, oh, I'll push it off, but I take these things very seriously because, as you know, being a woman, especially of color, like with aggressive, TNBC is so aggressive, right? So you miss an appointment, you miss a screening, you never know. So keep staying here longer is my goal.
Yeah. So let me go back to the proposed algorithm here, because I think we have questions for each of you regarding this. So it's easy if this patient gets a complete pathologic remission, pembro for the remainder of a year. But what if she doesn't, which again is going to happen in at least 50% of people? So then the question's kind of dicey. Do we put her on capecitabine and pembro? As Tiffany pointed out, 522 did not include a cape component. It was just pembro. What do you do in your practice?
Yeah, so you know, great question. I think as we mentioned, capecitabine wasn't incorporated into the trial as a sort of planned adjuvant therapy for those who failed path CR, but there were some patients who did receive adjuvant capecitabine, and so there was a subset analysis that looked at that. We know we've had safety data for the combination of pembro and capecitabine, and so prior to even the San Antonio meeting, in those highest risk patients who we know really unfortunately did poorly and in terms of event-free survival, if you failed path CR, that was still really a high-risk category. I tended to try to incorporate adjuvant capecitabine in addition to the pembrolizumab. Happy to see that in the subset that was reported out, there still remained an advantage to pembro on top of the adjuvant cape. I think the question also remains quite similarly for those patients with germline BRCA mutations, where we have adjuvant olaparib data. I'm curious what your thoughts are there, and would you be combining the PARP inhibitor and checkpoint inhibitor in those patients with germline mutations?
Yeah, I think that's probably even more dicey because we don't have a lot of good data at all. I mean, the CAPE numbers are somewhat small, but certainly enough that I think we're all comfortable giving the two together. So, and there was actually a question in the chat as well, which is in a triple negative breast cancer patient with a BRCA mutation positive, would you recommend neoadjuvant, adjuvant IO, or olaparib, hence the Olympia trial, or a hybrid? And I think that's what you're getting at. So would we do the neo part of pembro and then on the back end do olaparib, or would we not add it, or would we add it? And obviously we haven't studied it. So I think that's, you know, the difficulty. Then I think we get into side effects. You know, one of the compelling arguments against Olympia, and I'm actually a proponent of it, but against it, are the side effects. And especially in the adjuvant setting, and, you know, what happens with compliance, and, you know, how do we keep people on this for a total of a year, which is the standard recommendation. So I haven't been challenged by this yet in my practice, but I think I'd have the chat, and I certainly would consider it. What about you? Again, olaparib, you want to make sure that they've had full hematologic recovery. So, you know, if somebody has a beaten up bone marrow after anthracyclines, taxanes, and carbo, you know, that may be harder, because I do think there's an increased chance of MDS in those people that have not fully recovered. What do you use as your criteria, Tiffany?
Yeah, so I would err on the side of the eligibility for Olympia, right? Which, remember, it wasn't all comer triple negative breast cancer. It's not going to be the tiny 1.2 centimeter node negative. So a high risk population, germline mutation carrier. I would really contemplate overlapping in those that failed path CR. We do have several studies that have looked at combination checkpoint inhibitor and PARP inhibitor. And so there are safety data there for the combination. There's a rationale actually that they would partner well together. Obviously, we'd love to see data in the adjuvant setting of this, but in the absence of that, where I feel like there is some safety data there, my preference would be to try to overlap them. Mm-hmm. You know, we've seen the Olympia. Oh, go ahead. Sorry.
No, you go ahead.
We did see some quality of life data from Olympia as well, just reported out at San Antonio, and we can talk about that perhaps a bit. But you know, I think that given the impact of the PARP inhibitor in those germline mutation carriers, I feel like we want to maximize the benefits that we can.
I wanted to talk to Elyse, or to bring it up. You mentioned the issue about adherence to treatment when there are side effects. And I think this is where advocacy is really powerful, you know, in helping physicians to really know how to talk to a patient. You know, as a patient who had triple negative, I was on AC and Taxol. I had so many side effects, and it was debilitating in many ways for me. I call my doctor and they say, well, nobody else has those side effects, or we don't hear about that. But guess what happened after 14 years? I was on a call. We have listening summits at Tigerlily with about 20 or 30 Black women. And I mentioned the story of me having, you know, itching from Taxol and other side effects. And we had all these Black women say, me too. And it was shocking because we're not often offered trials, we're not in them. So we don't have treatments that target our cancers, but also side effects, right? But the other thing besides that is, you know, how do you talk to people about the importance of adhering to a trial or a drug, even when there are side effects? So my mother's a nurse, thank God. And when I wanted to stop treatment, she said, freaking not, like, you're not stopping treatment. So I think it's important to collaborate with patient advocacy groups to help them, to help us help you to talk to people, patients, because, you know, as a single parent, raising a child, working a full-time job, I couldn't be sick or out of the office past 3 days. So while we're talking about medicines, the human component is, how do you keep a patient who's having these side effects, is not be able to work full-time, or is uncomfortable, or taking drugs to get over the itching, whatever it is. So even creating materials and saying the importance of just investing in that conversation on why it's important to stay in the treatment, the trial, and or the treatment. That's where I think we can really be of support to oncologists, because that's really important. Because many patients choose to not adhere because of side effects and how they impact taking care of their families, or going to work, or having a quality of life right now, not thinking about the impact on their health and life in the future.
Yeah, it's sometimes hard when you're sick and dealing with those side effects to think about how you're going to feel about it 10 years from now. Right now, you just want to feel better. It's complicated. Yeah. I think you brought up a really important point, which is you need to identify the patient's support system, be it their family member, their church. I've had many of my patients of color bring in their ministers with them to help them make decisions because they trust them. And those are the people in their lives that actually help them to go forward. So I think that's something we forget about. You know, sometimes it takes too much time, but it really doesn't. At the end of the day, they will make sure that we're all on the same page as to what we want for quality of life and adherence to meds. So I think really very, very important.
Yeah, you all have a big job to do as oncologists. You know, you're busy, people doing really good work. But as a person, when you get cancer, you're not a cancer expert, and you have to become one in a week, if that, and make these choices that are going to impact your life. So I find that there's so much importance in that. There are things I can understand now that I didn't understand 5 years ago or 10 years ago. And so having that support from a church member, someone in your family in the room with you, but also to help you through the process of staying with the treatment, eating properly, dealing with mental health. All those things are wraparounds that are quite important. Not just the treatment journey, right? So I think having that additional layer of home support, because a lot of mothers, if you ask them what they would choose first over anything else, is their family, their children, right? At the risk of their own lives. And so it's really important to give them that support throughout the cancer treatment journey, especially when they're taking, in a clinical trial.
Yeah, absolutely. Before we leave, there are two more things I want us to cover before we leave neoadjuvant treatment. One is we've had 4 questions related to what kind of chemo drugs can we use for patients that cannot take anthracyclines. Do we offer docetaxel carbo with Pembro, or what do you do? What's the next step? Are there other options besides anthracyclines? Tiffany, your thought, and where are we with clinical trials at evaluating other drugs in the neo setting with Pembro?
Yeah, that's an excellent question. So, I think we do have data for, say, docetaxel, carboplatin as a combination, although I'm not aware of that with pembrolizumab yet, but certainly these combinations are going to be explored for sure. We've had docetaxel, cyclophosphamide, the TC regimen as an option, but really haven't seen that in the pre-op setting with pembrolizumab either. We've seen single agent PARP inhibitor data in the neoadjuvant setting for germline mutation carriers, but not yet the combination. So I think that there's a lot of data that needs to be generated to answer that very question. But certainly, as we've done in oncology all along, we have our aspirational regimen that is supported by the literature. And then we need to respond to toxicity that our patients experience and modify or reduce as needed. And so hopefully we'll be able to generate some of these data to help serve as a guide for alternatives.
One of the interesting things is traditionally our neo regimens came from our metastatic regimens and our adjuvant, and then we segued them to the neo setting. It used to be metastatic, then adjuvant, then neo, and now it's very much different. And particularly if we think that PD-L1 positivity does not predict for responses in the neo setting, it kind of makes things off. Can we really trust what we see in a metastatic regimen to be applicable in neo? I'm not sure we know the answer to that, actually, which may mean that we have to do the studies in neo as much as anything else. It'll be interesting to see how that sorts out. Before we leave neoadjuvant, I need to pick Terry's brain because you gave such a great talk on management of the axilla and in early stage disease. And I was wondering if you had like 3 key points, what would they be from where we are in 2021, almost 22, on new ways to decrease toxicity and still have great outcomes?
So when it comes to, again, de-escalating surgery to improve, quality of life and decrease morbidity, we've done it in the upfront setting, obviously with the establishment of sentinel lymph node biopsy for sentinel lymph node negative patients, and also for selected sentinel lymph node positive patients that present with clinical N0 disease, such as, for example, the Z11 trial. And other trials that have shown equivalent outcomes when you have 1 or 2 positive sentinel lymph nodes, as long as you're clinically non-negative when you went in. And so this has become pretty much a standard for the patients that participate in these trials. There's still some more work to do to augment the groups that belong in this category. But for those patients, I think we were able to de-escalate surgery upfront. Now, also we have shown, of course, that you can also meet axillary dissection in patients that have a little bit more burden of disease in the sentinel lymph nodes, 1 to 3 sentinel lymph nodes, and even with more burden in non-sentinel lymph nodes with the axillary radiotherapy versus axillary dissection with less morbidity, with significantly less lymphedema. So axillary dissection, at least in the upfront setting, has been substantially decreased in its use. And another way to decrease the morbidity is also to take patients through the neoadjuvant setting and downstage their disease. And then if they become or they are sentinel lymph node negative, then axillary dissection for those patients can be avoided. Clearly, that's so for patients that present with clinical N0 disease. If you have clinical N0 and you do neoadjuvant chemotherapy and then you get sentinel lymph node biopsy and it's negative, there's no reason absolutely to complete an axillary dissection. We then extended that for patients that are clinical N1 at presentation, and then the nodes become clinically non-negative. They have a sentinel lymph node biopsy. And now if the sentinel node is negative, I think we have shown that it's safe actually to not complete the axillary dissection, but you have to take some steps for those patients. Initially, we saw higher false negative rates, which then can be decreased if you remove 2 or more sentinel lymph nodes, if you do dual mapping. And then we realized that if you take the node that was positive before and it was clipped at the time of diagnosis when it was biopsied and remove the clipped node, that alone actually decreases your false negative rate almost to half, 5-6%. And if you add sentinel lymph node biopsy, in other words, take the lymph nodes that uptake the isotope or the blue dye, in addition to removing the clip node, the false negative rates dropped to almost about 3%, 4%. So we have made significant improvement from an initial a point where we had about 13% false negative rate if you were N1 and became clinical N0, to now dropping it down to 3, 4, 5%. And that's as good as it is up front. So I don't think we would do great service to the patients. This is not something that's been widely adopted yet, but clearly we have made significant progress in other meta-analysis. And of course, the more important endpoint is local recurrence in the axilla. How much local recurrence do we see? And there we don't have a lot of data yet, but the data that we have so far show that the rates of local recurrence in the axilla are very low, probably less than 2%. Even starting with positive nodes and converting them to negative.
I'm very impressed with how little recurrence we see now with de-escalation. Pretty impressive.
And there is variable follow-up in some of the studies, but there's some studies that go up to almost 8-9 years and they show very low rates. But the last sort of bastion of resistance now is the patients that still have a positive sentinel lymph node after neoadjuvant chemotherapy, despite the fact that we're clinically N0. And for the clinical N0 after neoadjuvant chemotherapy. And for those patients, we're now completing an alliance study, 11202, that randomizes patients to completion axillary dissection versus not, assuming that they all will get comprehensive radiotherapy because they're still not positive. If that study shows no benefit from completion axillary dissection, we actually will take another chunk of patients that actually would not need an axillary dissection. The last point to make here, though, is that if you still have positive sentinel lymph nodes after neoadjuvant chemotherapy, even if they have micrometastatic disease or very low volume micrometastatic disease, I think there is still significant risk of having no sentinel lymph node metastasis. And for those patients, axillary dissection is still the standard. But we hope with the 11202 trial, we'll actually do away with that if the data are supportive.
That certainly would decrease morbidity. One of the abstracts we're going to talk about near the end is lymphedema. Right. So, in that setting, they're all getting radiation. And, if you have to do a complete axe dissect, the chance of lymphedema really markedly increases. So it'd be great if you could avoid that. Yeah.
Absolutely.
What's your crystal ball tell us? Is this as good as we can get? 2 to 3% sounds pretty darn good. Where do you think we'll be in 5 years with this?
In terms of local recurrence, or
right?
No, I think my crystal ball is that it's going to be very low, because we see the same thing in the upfront setting where, for example, in Z11, about 27% of the patients had left positive non-sentinel nodes, as we know from the other arm. In the Amoros trial, 33% of the patients had positive non-sentinel nodes. And then even in San Antonio, the Synodar-1 trial was reported, where in this trial, same design, positive 1 or 2 positive sentinel nodes up front, completion axillary dissection versus not. But 44% of the patients in the completion axillary dissection group had positive non-sentinel nodes. And despite that, this study also showed no difference in disease-free and overall survival. So again, there is a disconnect to some extent where you could be leaving disease behind in about 30, 40% of the patients, and yet have a local recurrence rate of about 1 or 2%. So for whatever reason, either because of systemic therapy or because of radiotherapy, those patients have the nodes that do not progress to actually local regional recurrence in the axilla.
I think we all feel that if you have a positive sentinel node after neo, you're in trouble systemically as well. And I think that reinforces how important it is for us to figure out the optimal adjuvant regimen for these people that have remaining disease. And that's true obviously in the HER2 space as well as in the triple negative space. We need to better figure out what kind of combinations of adjuvant therapy we need to recommend these people. Yeah, so. I think I don't see any other questions specifically about Neo. Before we leave the Pembro issues and all the Keynote studies, let me just briefly mention what I thought was another important update, and this is in the metastatic sphere, not neoadjuvant or adjuvant, but Keynote 355, the data of which we've all seen before. And this abstract was also an oral presentation looking at PD-L1 expression cutoff for Pembro. And as you recall, the original study showed improvement when Pembro was added to chemo, and the chemo now is Taxol or Gem Carbo. So a little bit different regimen, where again, with the usual endpoints. and the pembro arm was superior both in PFS and overall survival. However, again, metastatic, not neo or adjuvant, the improvement was seen only in those patients that had PD-L1 CPS combined positive scores of greater than 10. And they did a nice analysis of actually 4 cut point levels of less than 1 to 9%, 10 to 19, and then greater than 20. And although there was some benefit seen in all of them, it seems like the CPS cut point of 10 was the best. There was a hazard ratio of 0.66. So again, I think it emphasizes that we still, I guess we still need to do PD-L1 testing in these patients. Tiffany, what are you doing with this now? Are you, do you do them in-house at Memorial or?
Yeah, so we previously were using SP142 and over time stood up an assay to be able to do a CPS score and use that 10 or greater cut point, really reinforced by the 355 subset analyses. So we are able to do that in-house.
So you do not do that with any adjuvant though, only in your metastatic, is that right?
Metastatic, correct.
What about in Orlando? Are you using PD-L1 testing just in the metastatic setting or?
Yes, same.
Yeah, so exactly the same. So I think that's here to stay until we prove otherwise. I think it's going to be fascinating to see why it's important in one subset and not another. So that's going to be very, very interesting, I think. So we're talking now about metastatic triple negative. And I think one of the most exciting things is that we've now seen ADCs, antibody-drug conjugates, so very important in drug delivery for our patients, not just with HER2 positive, that's where we first utilized it, but triple negative. And we all know that sacituzumab, govitecan, otherwise known as Trodelvy, has great responses in the heavily the first line and second line metastatic triple negative population. And now there's a new kid on the block, which seems very exciting. And I know, Tiffany, that you were quite involved with this trial. And I'm probably saying it wrong, but it's Dato-DXd, right?
That's the simplest. Yes, absolutely.
Okay.
Dato-DXd.
Yeah. Okay. Yeah.
Right.
DXd. Yeah. Do you want to tell us about that study or?
Sure. I mean, so what was presented at San Antonio was actually the cohort of patients with triple negative breast cancer that were on this phase 1 study that obviously had cohorts of other subtypes. They've previously reported on non-small cell lung cancer, and we had a little sneak preview of some of these data at ESMO. But Dato-DXd is an antibody-drug conjugate where the antibody is targeting TROP2. So that is a similar, same target as sacituzumab govitecan. The linker is a cleavable linker, and the payload is a topoisomerase inhibitor, deruxtecan. So essentially, linker and payload are similar to what we've seen from trastuzumab deruxtecan, which we know is FDA approved in HER2 positive breast cancer. So this antibody drug conjugate Dato-DXd was studied, forgive me, my lights keep going out on me. I'm sitting still. I'm going to wave my hands periodically. So this, as I said, phase 1 study, single arm Dato-DXd enrolled about 44 patients with triple negative breast cancer. And the primary objective obviously was safety. The dose finding was clear and this cohort was expanded. And the population that were on this study, had about a third of them had de novo metastatic disease. About 10% of them actually had stable treated brain mets. And I think that what was most impressive, median prior lines of therapy was 3, but about a third of these patients had previously seen an antibody drug conjugate with a similar topoisomerase payload. Mm-hmm. And of that third, 10 out of the 13 patients had sacituzumab already. So really not only heavily pretreated, but pretreated with an agent to the same target with a topo payload. And the responses were pretty impressive for a phase 1 study. So, in the overall intention to treat population, response rates of about 34%, disease control rate about 75%. And then they did a separate analysis of pulling out the patients who previously saw sacituzumab or a topoisomerase inhibitor. And the overall response rate was more than 50% and disease control rate about 80%. So clearly a signal of activity. They hadn't reached median duration of response yet. Spider plot looked pretty interesting. That looked like responses were pretty durable. And the other piece, I think also that we need to think of in the same breath as efficacy is what was the tolerability like? What was the toxicity here with this ADC? And the most common
part. Yeah, this is the exciting part, the drum roll.
Yeah. Right. So when we think about what do we see with SASI, well, we see diarrhea, we see cytopenias, much less of that here. And then what the other sort of area of interest is that this linker and payload with trasderuxtecan was associated with pneumonitis and interstitial lung disease. So in this small series of 44 patients, there were no cases of drug-related ILD. Probably the most common adverse events were around nausea and some mouth sores and a bit of vomiting and fatigue. But, so far feeling like a manageable, mostly grade 1-2 adverse event profile. So I think it's an agent to keep an eye out for. Randomized phase 3 studies are planned that hopefully we'll be seeing in early 22. But I think just the construct of ADCs has really transformed really all of the subtypes of breast cancer these days. It's really encouraging.
Mm-hmm. Very interesting. I had somebody tell me, so you're just giving more chemo, but it's just hitting the cancer cell. That's not quite accurate because the drugs are a little bit different. The payload's a little different than the regular IV that we used to give. Plus, there is a bystander effect in some of these ADCs. You do see some killing in the adjacent tumor cells and not just in the tumor itself. So depends a little bit. So I found the toxicity just, really gratifying. It's going to be interesting. Obviously small numbers, only 44 people. I think that's probably the biggest thing. It's phase 1. So, when you add another, several hundred people in a phase 3 study, it may change a little bit. What will the comparator arm be in a phase 3? So you design these triple negative studies. Would you be brave enough to do one ADC versus another ADC? Or what kind of comparator arm would you think would be a good phase 3 trial?
Yeah, I think that there are plenty of areas of unmet needs. So, one question to ask is, do we just sequence these? And do you do a trial of seeing how do you sequence them? Are you looking at standard of care chemotherapies in folks who previously were exposed to a similar target and payload? Or, is there an opportunity to leapfrog because we have not seen first line data? We have an area of unmet need in a population of patients who fail path CR, right? Can we do better than capecitabine?
Yeah.
We've seen data recently of platinum versus capecitabine in those who fail path CR, but what a great opportunity to start to move these highly active ADCs into that space as we have greater safety first, obviously. So I think it's really a challenge, and it will depend on what line of therapy you're trying to design that study for.
I love the concept because we all like CAPE, but really the data is not as great as we would hope. You still have substantial relapse in those patients who have adjuvant CAPE for 6 months. It's better, but I think you're right. We clearly have the space and an unmet need there. So it'd be fascinating, kind of like a Catherine trial of using the standard of CAPE, but then using the comparator arm as one of the ADCs. So I think that would be fascinating to see. Yeah. So, Maimah, we're talking so much about toxicity, and when I looked at this, I was very struck by how little toxicity was reported for this phase 1 study. Again, small numbers, and I always put that caveat out there because we've all seen the study in which all of a sudden when we follow longer, we may have more toxicity, but certainly in the short term, it appears to be better tolerated. How should physicians and nurse practitioners approach toxicity to our patients? Should we tell them numbers, or how do you think patients best learn about toxicity from drugs?
I think being honest is really important. I always tell doctors, talk to me the way you talk to your daughter, or you're someone you love, right? So when you talk to a patient, first of all, they're totally overwhelmed about what they just heard, right? Cancer means for most people, like, you're going to die. That's not true any longer in every instance. And then the toxicity levels can be high, right? So explaining what that means short term is important and what it means long term. For example, things like, cardio issues, or it could be things like chemo brain or nausea. So explaining each side effect, explaining how it could impact your life, but then explaining on the inverse side, the importance of, again, adherence, right? But I always tell people, tell me the truth, tell the patient what to expect. A patient who's educated and empowered is the best partner for her own health and with her doctor. So it's really important to be honest upfront and tell the caregivers, who's with the person at home. So when they're having a side effect and they're not feeling well, or a drug could have short or long-term issues, that person that loves them at home can help them to navigate and stay in the clinical trial or the treatment. I think for me, being a patient, I was aware of the side effects, short and long term. But when I looked at triple negative breast cancer outcomes, I stayed in treatment, because at the end of the day, I would rather have some chemo brain, which is annoying even now, and other things, and be here for my daughter, which just finished high school this summer. When I learned to have breast cancer, she was 3 years old. And because of, I stayed in my treatment and I did my screenings on time and changed my lifestyle. My doctor is my best buddy. We still text and talk all the time. We had a great relationship. She leaned into me. She held my hand and she told me, she said, "You can trust me. I got you." And we were always honest about the disease, what could happen, good or bad. She was honest about the treatments, about the surgery, about the entire process, but she never let me go. And so I think it's a relationship that you have to have with your doctor, right? This person holds your life in their hands pretty much. And also on the other side, you also, the more you learn, the better you can be as an empowered patient. And so that's why it's been important to me to be an advocate, to learn more, to meet people like you all, to meet oncologists and scientists, to understand what are the new innovations, what are they going to do, who can they help that needs a medication right now, and then pass it on to my patients. So honesty, compassion, leaning in, and just holding our hands through the process is really, really important.
Yeah, I think those are empowering worlds. And, I think looking at San Antonio, even virtually, it was so exciting to see these big improvements. These are not just 1 or 2 percentage point advantages. These are light years better than where we were 5 years ago. And that is so very, very gratifying. So, you're very lucky, but your patients and your followers are very lucky because they are having you as a big advocate for them and a spokeswoman for them. So, we thank you all for everything you're doing with that. Very, very empowering.
Thank you.
So I do want to segue to our next topic, which is going to be side effects of treatment. This time it's not chemotherapy, but it's the surgeons, and that's our radiation oncologist, and this thing called lymphedema. And, when women are diagnosed with triple negative, they're terrified, but they're also terrified when someone says, "Oh my gosh, you're going to have surgery, you're going to have a giant arm and it'll never go down." And so Memorial did a very interesting single institution, single site study looking at the significance of race on the risk of lymphedema. And it looked at women who had axillary dissection. And as we've heard just from Terry, not everybody has an axillary dissection today. And in fact, those numbers are certainly going down. We're choosing more wisely and following other criteria. They collected factors such as race, age, type of surgery, stage of cancer, whether patients had neoadjuvant treatment or not. And my assumption is, since everybody needed an axillary surgery, I think they all had radiation, but I'm not actually clear from the abstract, and maybe Tiffany will know the answer to this. There were 304 patients that underwent axillary dissections between November 16th, and I think this got shut down just as the pandemic erupted because they stopped enrolling in March 2020. That's when all of our studies pretty much shut down. And there were 276 patients evaluable, 60% white, 20% Black, 11% Asian, and 6% Hispanic. And they considered lymphedema as being present or positive by arm volumetric testing that was performed at baseline, post-op, and then every 6 months for a 2-year time period. and anything greater than a 10% change from baseline what's considered to be positive or the presence of lymphedema. And actually we can talk with Terry about how he diagnoses lymphedema too. I think that's an important point. After 2 years of follow-up, there was lymphedema identified in the intent to treat population at 24, or almost a quarter of the patients had lymphedema. And if you look at race, those women, a Black 39% with lymphedema, white 20, Asian 23, and Hispanic 27. They were able to tease out some risk factors. In addition to race, women who had neoadjuvant therapy were 3 times more likely to get lymphedema. And again, I don't know if that's drugs. We don't usually think of lymphedema as causing, or as chemotherapy drugs causing lymphedema. I think it might have been a marker for more aggressive stage, and I guess we can kind of talk about that as well. White and Black patients tended to be older, and BMIs tended to be higher in Black and Hispanic patients. And there was more node burden in 1 disease in Black patients, in 2-3 disease in Hispanic patients, but white women actually had more nodes removed in general. And patients that had breast conserving surgery were more likely to have lymphedema than maybe because every one of them had to get radiation. And they concluded by their multivariate analysis that both Blacks and Hispanics were about 3 times more likely to develop lymphedema compared to whites with an axillary dissection. So I think this is clearly a quality of life issue. And I know, Terry, you've been dealing with this probably your entire surgical career. Any thoughts or?
Yeah, I mean, I think there's a very nice data coming from, a prospective study in a large institution with a lot of patients. When you look at the data, you look at the conclusions, and I mean, the data suggests that, Black women had more lymphedema, again, patients with breast conservation, mostly because of radiotherapy. And one question that sometimes remains unanswered is whether it's still a confounder of stage of presentation, response to therapy. You adjust for all this in the models, but sometimes you may not be able to adjust altogether. So if it's very difficult to prove that it's just, related to race or to confounder factors of that. But nevertheless, those patients, about 25% lymphedema rate is about what we expect with axillary dissection. With radiation, sometimes it can be even higher.
Mm-hmm.
But the good news, I think, again, is in general that we now don't do this that often. And, with a sentinel lymph node biopsy, the rate of lymphedema is usually about 3-4%, and sometimes it's mostly not even clinical lymphedema, it's preclinical. The other thing that we are now embarking more and more, and that's again institution variability there, is procedures to reverse blood flow to the axilla. So in our place, we are very much offer patients the lympha procedure preventatively. This is a lymphovenous bypass for patients that have axillary lymph node dissection. And admittedly, the data are still early, small studies, there were small randomized trials and mostly single institution studies, but they do show, compared to historic controls, if you like, that the rates of lymphedema are lower. And so we don't do axillary dissections as much, but if we do, we typically offer patients the lympha procedure. It does not allow to the morbidity. The axilla is open right there when you do the axillary dissection. There are other ways, of course. The axillary reverse mapping is another way that you can map the lymph nodes in the arm and avoid taking them out, or the lymphatics when you do an axillary dissection. So we're waiting. There's a prospective trial now with the cooperative groups looking at axillary reverse mapping. So we try to minimize the use of axillary dissection. We'll customize our radiotherapy, but also if we do, we're trying to find ways to actually improve of lymphedema, because obviously, as you know, it's a chronic condition. It's very difficult to treat. You can never almost control it. BMI, as you know, is an important factor also for lymphedema. And obviously, I think I've seen patients actually who lost weight and the lymphedema went away based on a bariatric procedure, let's say, and then when they actually gain some weight again, the lymphedema returns. So it's a complex factor. But again, a serious problem that I'm glad that we had the notoriety in this meeting, and more now people are thinking about it and act upon it.
Do you use a pre-Viver type clinic? Do you send everybody with positive nodes for OT lymphedema management before surgery, or?
Actually, pretty much every patient that we operate in the Axilla, even if they have the same lymph biopsy, are seen at the lymphedema clinic, either preoperatively or postoperatively. And so everybody's followed by the lymphedema. They give them a lot of instructions in terms of what to do and how to do, and assess them for lymphedema. And some of the data on the lymph procedure we collected it prospectively, and we're looking at it now to see if we can expand that cohort and see our experience with doing this procedure almost for now 3-4 years.
Yeah, I know there's several lymphedema trials ongoing now. One is the reverse mapping. I think that's really going to be an important, looks so promising. I also think that how we talk to patients about the risk of lymphedema is, obviously important. Maimah, can you comment? Did you have a discussion about lymphedema with your surgeon before you had surgery, or did that ever come up?
She mentioned it, yes, but I didn't experience it, but I have many patients who I've worked with who have, and it's very, it's a quality of life issue. It could be embarrassing. It could impact their relationships. So I think, it's important to give patients the education before they go into surgery to know what's going to happen, what could happen afterwards. But on the other side, there've been some really, cool things done. There's some groups that make amazing, armware gear for patients to help them. I mean, I think the cancer journey, to your point, is there's a lot to digest, to live with, but there's ways to find a better quality of life dealing with cancer, and there are ways to make your experience, how do I say, to be where you are in the experience. And so one of the things we do at Tigerlily is talk to our patients about what to expect, like lymphedema, like fatigue, like nausea, and things like that, to hold their hands throughout the process of treatment as well, and to help them do what I call pockets of joy, to find ways to have joy throughout the process of, if you have this wrong, well, this is working right, or if this happened, what can you find to be able to get you through the process of treatment. But some patients I found of color are not talked to about certain things. And that's why I think health disparities, things like that do exist, not just in treatments, but in terms of, people adhering, because they're not often told what to expect. And when you know what to expect and you experience something like lymphedema or a horrible side effect, prolonged nausea, exhaustion, it can impact your adherence to care. That's why I always go back to the importance of, listening, leaning in, learning, and holding your patient's hand throughout the entire cancer journey.
Yeah, if I can add, I mean, we definitely need to educate patients, because some of the long-standing beliefs about what will cause lymphedema, what you can or cannot do, have now been debunked. For example, I mean, they say don't fly, don't do vena fractures, don't do blood pressure measurements on that arm, and most of that now has shown not to increase the risk of lymphedema. What is very important is infection in the arm. So by all means, we need to advise patients to avoid things that can put their arm at risk for infection, because then the risk of lymphedema goes higher. And this has been one of the independent predictors in multivariate analysis.
Telling the patient too what they can do, because I mean, cancer robs you of so many things, right? So it does, right? I mean, it impacts your entire life when you're in it. Even when it's over, it's never really over. So telling a patient, okay, maybe you can't do this, but here's what you can do to enjoy your life right now, whether you're early stage, or metastatic.
Right. And for example, I was going to add that exercise, for example, was something that initially people thought that you shouldn't exercise the arm. And now I think the opposite. It's perfectly okay to exercise that arm.
Yeah, in fact, we want people to be out there exercising. That's key. It's interesting. I think hospitals still will tell women who've had surgery, either breast conservation or mastectomy, no needle sticks on that arm. And there's it's 10 years ago. There's no data for that. It's kind of interesting.
Don't identify it as a significant predictor anymore.
Yeah, exactly. When do you tell a patient that she will probably not get lymphedema? Do you specify time periods, Terry? Do you tell them first 2 years or?
Most of this, so 75-80% of lymphedema occurs within the first 3 years. So probably the first 2 years are the more important one. But again, sometimes delayed lymphedema can occur if you have an infection even later on. So you have to be very careful. But the first 3 years is the more important.
Yeah, a bad cellulitis even 5 years later can really set you up for problems. Yeah, yeah. Have you seen any improvement in lymphedema in patients that develop delayed lymphedema, like after cellulitis or something? Are there surgical procedures? I know we have a couple people in the state of Ohio that are looking at that.
Yeah, you could do the procedures that we do to prevent lymphedema. Mostly they're developed for patients that have lymphedema. So you can do lymphatic lymphovenous bypass. You can do lymph node transfer, where you take a pedicle of lymph nodes from the groin. Usually you transplant it to the axilla and anastomose the vessels. That doesn't work as well, we believe, as the lympha, but obviously it does decrease lymphedema in some patients as well. So yeah, so we can treat them, but in general, because lymphedema has different phases, the first is more of the liquid phase that is fluid, but then after that there is fibrosis and the fluid gets very well established in the interstitial space. I think dealing it up front or as early as possible is probably advantageous, and not wait till it becomes more established.
I had a question of my own as a patient. So as a patient, I wonder, in your hospital centers, we're having this great discussion about all these different findings and side effects and all these things. Do you all engage in, with patient roundtables or patient summits to really share this kind of thing with patients? I find that people don't often know patients don't often learn about scientific advances until they have cancer or until someone they love has cancer. So, what do physicians like you all do I know you're busy, super busy. What do you do in your setting to reach patients in a way that they can learn to understand what to expect during treatment, what could be the side effects long term, and even things like the advancement we've learned, from San Antonio Breast in the past week?
Yeah, no, we do. All of us do go out in the community and speak to patients in different settings. We invite them to participate and educate them on breast cancer advances. And sometimes, this is kind of the best talks I like to give, because you get all the important questions, and it's so nice to relate some of the optimism and new treatments for patients and educate them. And as I said, you get probably the best questions you get is from patients, not so much from physicians. So yeah, we do a lot.
Makes you think more. Yeah.
Absolutely.
Yeah.
What does Memorial do? How do you do it in your own practice? How do you update your patients on what just happened last week?
Oh goodness. So I think it really is a multifaceted approach, right? It's one-on-one education, it is groups, it's lectures, it's community outreach. Because I think there are a couple of themes that I'm hearing. Number one, it's so important to just disseminate the hope of what's on the horizon, to know that there's tremendous work going on to improve outcomes. It's a great opportunity to show thanks for participation in clinical trials, to make that link between the work and the efforts and your contributions translate into these meaningful benefits for the breast cancer community at large. And I think what I find so really important in those meetings is debunking some of the mythology that's still out there. And, in some ways it's a safe place to maybe ask a question of a doctor that you don't know, that you might not feel comfortable asking of your own doctor or your own care team. So I think dispelling the mythology to be sure patients aren't limiting themselves in ways unnecessarily, and being sure that they're, really following safe practices and not doing something that might be of harm.
I think too, patients can be, really powerful innovators, So Tigerlily's been holding a session with San Antonio Breast in partnership with AACR for the past 2 years, which they took our inclusion pledge and they've been doing. So for the first time last year, they had a 4-hour session on health equity with a Black patient leading the session, and patients of color engaging, of all colors, in all stages. And last week we had a 3-hour session on health disparities. But when you bring a person who's a patient and into a setting where they can talk to a doctor and a researcher and scientist and ask questions, amazing things happen. Because one of my friends, Julia Mowers, always says, the doctor's an expert in treating cancer, but the patient's an expert in living with cancer. When you come together in that sense, you have a powerful dynamic because there are things that you all may not see, or we can say, well, that's never going to work, or it doesn't work for me. What about these other things? And so it's really important to have those discussions with patients in an ongoing manner. And so one thing we do is we do listening summits once a month, and just we talk to physicians, we get them on the phone on this summit, and we have a bi-directional conversation. So the first session is just patients talking about an issue and physicians listening. They don't talk, they just take notes. Literally is a reverse. And then after 2 weeks, the doctor digests what we've told them, the patient has told them, and they come back and they talk about solutions they can do to create together as a patient and the physician as allies. And I think that's when you can see magic happen, right? And you co-create things together.
I love that quote. That's so telling. Yeah, very, very good. I know in our center, we've always had, I would say, larger outreach and not something daily. I mean, we all talk about to our patients, gee, in fact, I talked to people this week about, gee, this is what happened, and how this may change our offering to you on certain things. But I think one of the things the pandemic has done is it's made us realize that we can't have as many meetings in real time. And so we're trying to do more virtual things. And I think it's going to be necessary, like what we're just doing now. There's no reason why patients could not listen to this. Some
exactly
understand perfectly. Some people will be lost in the weeds, but they're going to get the main messages. And I think that now that we have so much more availability for patients as well as healthcare providers to access all these webinars and programs, and I thank Telehealth Conferencing for making this venue possible, because I think it's important not just for us in healthcare, but also for our patients. And they can have access to this as well. So I think that's quite important. We have a few remaining moments. There is one question in the queue that I do want to bring up. It kind of goes back to what we talked about early on regarding immunotherapy and metastatic triple negative. And Tiffany, I'm going to turf it to you. The actual question is, why was the impassioned approval withdrawn? Was it a function of how the study was designed? You're big in design of clinical trials. Clearly, atezolizumab is still available in Europe. It is withdrawn in the US for its breast cancer indication. So what happened and what's your thought?
So, so I can't speak to decisions around the agency level and around Roche Genentech, but I think that what we know from the data is the original large randomized phase 3 study of nab-paclitaxel with or without atezolizumab was a positive study in terms of progression-free survival, with a trend and a really sort of compelling difference in overall survival. The subsequent study, what was, I think, meant to be a confirmatory study of paclitaxel with or without atezolizumab, was a much smaller trial with, I think, a very different statistical design. A lot of people have wondered why that study didn't necessarily meet the primary endpoint, right? Progression-free survival did not appear to be any better with the addition of atezolizumab. And there's been a lot of discussion around, were the study populations comparable? Were they matched for metastases? Is it the role of steroids with paclitaxel versus no need for them with nab-paclitaxel? I don't have the ultimate answer, but part of me thinks that this is related to statistical design and power to notice a difference. Nevertheless, without that confirmatory data, looks like atezolizumab was withdrawn from its first line indication for metastatic triple negative breast cancer in the PD-L1 positive subset. There is still tremendous work going on looking at atezolizumab in patients with breast cancer. And we hope to see the data from some of those early stage studies in the adjuvant setting. We know there have been neoadjuvant trials. I imagine we'll see more data from additional metastatic trials. And, we all have patients who have been on atezolizumab deriving benefit. And for those patients, I've continued their therapy. I have not changed their treatment. And fortunately, we're still able to access atezolizumab. I think we'll need to see what some of the additional data shows us.
Yeah, can you still hear me? Because something just happened to my access. Can you hear
Yeah.
me?
We can still hear you.
Okay, I'm not sure exactly what happened here, but I'm going to just keep talking and I'll see if I can get this relaunched. I think that's really very, very important. I have had a few people ask me if they've switched into Pembro from atezolizumab. Clearly, I have not. I don't know what you've done in a patient that's responding.
Yeah, so if my patient's been deriving benefit, I've continued them on atezolizumab and have been able to keep that going.
Yeah. So in our remaining few minutes, I'd like to ask all three of you to comment on what do you think will be exciting in 2022, ASCO 2022? What clinical trials are we looking forward to hearing more about in ASCO? And then also, what new unmet need, what one clinical trial should we be designing here in the future? I suspect that Tiffany has been thinking a whole lot about this, so I'll let Tiffany go first.
Well, I think we have several unanswered questions, and just narrowly within triple negative breast cancer, I think one question about adjuvant checkpoint inhibitor really remains unanswered. So we're all wondering, do we really need the full year? We've seen data from Gepar Nuevo where just having about, I think it was 12 weeks, or a really short duration of pre-op checkpoint inhibitor in and of itself is associated with an impact in event-free survival. So I think that duration of checkpoint inhibitor question is important. Forgive me. So that's certainly an important question. I would also love to see the maturation of some of the adjuvant trials, right? We have a group of patients who, for whatever reason, did not get neoadjuvant therapy, go to upfront surgery and are found to have a large tumor, positive nodes. And with the current indication from Keynote 522, I've been unable to access checkpoint inhibitor exclusively in the adjuvant setting for those patients who missed the chance with pre-op therapy. So, we have several adjuvant studies that should be maturing and look forward to seeing those. And then one of the third sort of studies that I'm really curious about is seeing the data for single agent adjuvant checkpoint inhibitor following completion of adjuvant therapy, right? Where we have the pembrolizumab trial, hopefully soon to report out. Obviously seeing ADCs, additional work with ADCs in combination with checkpoint inhibitor and moving those up earlier. And I think one of the areas that is incredibly hot that we'd love to see come to fruition is the ability to monitor and detect cell-free DNA to perhaps be an early indication of recurrence of disease and to have a powerful intervention to change the natural history of disease. And we need both of those linked, not just detecting cell-free DNA to tell somebody they're at higher risk of recurrence, but to be able to do something impactful about it and change the survival.
And your crystal ball, would you think that might happen in the next 5 years?
I think those trials are being designed. The technology is changing so rapidly that even just the cell-free DNA technology, study to study that we've seen in San Antonio has evolved. So I'm optimistic. I'll put my nickel down. Our drugs are better. Our detection and level of detection is improving. So I'm hopeful.
Yeah, I think our detection is going to be there before we know what to do with it, So I think you need both parts. So, yeah. Okay, Terry, in the world of surgery, what do you think?
Well, in the world of surgery, I think we will still, we're waiting to see the results of the 11202 trial, in patients that present with positive nodes and convert them to clinically negative, but still sentinel lymph node positive. I think that will potentially put another nail on the coffin of axillary dissection. We also need to expand our data for upfront sentinel lymph node biopsy node positive patients with mastectomy patients, and there's some studies that will report on that. And also, we heard in San Antonio the quality of life from the so-called INSEMA trial, which is a trial that actually randomized patients with clinically low risk to sentinel lymph node biopsy or no sentinel lymph node biopsy at all. And then patients that had the sentinel lymph node biopsy that was 4:1 randomization, then they had a completion axillary dissection versus not if the sentinel were positive. So potentially we could be avoiding even sentinel lymph node biopsy for patients that are low risk if the study show no benefit from performing the sentinel lymph node biopsy up front. Nowadays, we can make these decisions about systemic therapy without necessarily needing to know the nodal status. So those studies are also important. So again, and then of course, we'd like to see more data from lymph procedure and see whether we can see in a randomized setting that this really improves, as well as the Axilla reverse mapping, but this could be a little bit further down the road.
I think it's going to be very exciting next year as well. So from our patient perspective, what do you think you'd like to see as that patient advocate?
My crystal ball and what my nirvana is that I want to see more trials designed with patients, especially those of color, so they're diverse. I want to see patients at the forefront of the entire process and the entire process. So there's better access, better understanding, better trust, better adherence, and better treatments for patients who are Black and brown. I want to see that we are designing trials that are diverse, that have numbers that we're working towards achieving, right? Not just we're going to try and get X amount of Black patients, but that we are going to get them because it's our goal, and that people are challenged to make those goals a reality. I think that we need to be doing a better job, which we're working towards now, in being in the community before people want to ask for a trial, to build trust with physicians and with pharma. And so I would challenge, industry, they're doing better, way much better, physicians to really work to build trust with patients, to be able to get them involved in trials. I think that we've seen a lot. The COVID's pushed us all to be more innovative, but I think that in terms of health disparities, there's still a lot of work to be done. So policy change around health equity to ensure that we're meeting numbers, that we're, making the bridges go away. Gaps go away for one. And just again, people need to understand what trials are about. I think at the grassroots level, people are hearing more about trials and why they're important. When you ask the average person what trials are, they think experimentative, guinea pig, placebo effects. So who's behind the trial? What does it mean? And how are the drugs in your cabinet, in your kitchen, how they've gone through trials. So for me, if we go through those kind of processes and really make them in layperson's terms, build trust, make them less clinical and more personalized, we can build that trust, build transparency, and transform our clinical trial system. And as a result, transform getting patients who need it the most, the best effective treatment sooner.
I think we all wish for that, communication and open up the bridges. I think that's so very, very important. I think our time is just about up. So first of all, I so much want to thank each and every one of you. Tiffany, always a pleasure. And Terry, I was in awe. Your talk was fantastic at San Antonio. And, Mamah, keep doing those great things. Our patients so need you. I'd also like to extend a great deal of thanks to Total Health Conferencing. I think this answers the need that certainly you brought up, Maimah. How do we disseminate knowledge? And this is so very important. And finally, we would not be here without sponsorship. And this program tonight was sponsored by Pfizer, and we are in their gratitude as well. So with that, I think we have no more questions in the chat, and I think we can conclude tonight's presentation and thank everyone for participating after work. Thanks.
Thank you.
Thank you.